One change, we'll be hearing from Dr. Lynn Silva. Welcome, Dr. Silva.
Thank you, Mr. Chairman.
Thank you. Assembly member, do you want to open or have the issue framed first? And then
I
open?
just wanted to open and then allow the doctor to add some more detail. I just wanted to, and I also have like 3 committees going on at the same time, so I appreciate your indulgence. I just come in here to speak on support of this important issue, our state investment towards public health efforts, which will hopefully help every single Californian, regardless of their socioeconomic status, race, ethnicity, or place of residence. Earlier in the year, I was discussing kind of health access with my staff, and how do we move beyond our current health system, and really kind of digging deep into the fact that we're kind of in between the health system 2.0 and health system 3.0. The first one was preventing diseases. The second one is increasing access. You get hurt, you get injured, you get sick, you go to the doctor and they fix you. And that has been, access has been greatly expanded because of the Affordable Care Act, an increase in Medi-Cal. But we now need to move beyond that health system or build upon it in order to make sure that we can actually start reducing the chronic diseases that are impacting a lot of our communities. And oftentimes it's done in a way that is inherently discriminatory by the fact that it's often disproportionately people of color, people of low economic status, and people that just, even if when they have access, their health outcomes are just more negatively impacted by their environment, where they work, where they live, where they go to school. So we came up with this idea of creating the Health Improvement and Innovation Fund. And what it would do is ensure that all Californians are able to achieve optimal and equitable health. The goals of the Health Improvement and Innovation Fund include set a path towards health equity for all Californians, establish a culture of health in California, specifically through upstream prevention, address key risk factors for chronic disease, including social determinants of health, empower local action and public health and prevention programs, secure financial sustainability through California-based control of primary prevention efforts, and the sources of funding for public health and prevention programs are perpetually threatened, currently declining from past levels of prior funding and are subject to significant restrictions. Strategic investment in upstream primary prevention will protect, not deplete, government health programs. Investment in prevention has a strong evidence base of positive returns on investment through reducing health care costs on a long-term basis. Having the opportunity to sit as the chair of appropriations, we don't actually look at bills about how much money they're going to save in the future. We look at the current static cost to the budget. And sometimes we miss out on actually taking steps to really reduce long-term cost. And the only way, as you, Mr. Thurman, understand, the only way that we're going to actually start reducing our long-term health care costs is if we can actually start addressing the chronic diseases that are plague a lot of Californians and also a lot of Americans. So I'm here to speak in support of this concept and also in support of the trust fund is Dr. Lynn Silver, a public health physician. So I want to just thank you for the time to say a few words in support of this idea.
Senator Mayor Gomez, thank you for your interest and your leadership in this topic. Thank you very much for your testimony.
And $360 million is not that much money in the grand scheme of things. So
this he says, as the former approach chair.
Last year, the cumulative cost of all bills combined was $17.5 billion. So we have some ambitious.
We don't disagree. We don't disagree that every dollar spent on prevention is a great investment. Having said that, we're not taking any action on this today, but we do think it's an important topic for discussion.
No, thank you, Mr. Chair.
Thank you, sir.
Thank you.
Thank you, Assembly Member. Dr. Silva.
Thank you, Mr. Chairman. My name is Lynn Silver. I'm Senior Advisor for Chronic Disease Prevention at the Public Health Institute, but today I'm speaking for the Health Officers Association of California and also as convener of the California Alliance for Funding Prevention. As a former health officer for Sonoma County and a board member of HOAC, I'm here today to request your support for the fund that Assemblyman Gomez just described. This is a proposal that is both modest and revolutionary. It's modest because $10 per person is not too much to ask for preventing chronic disease and injury in California. It is also revolutionary why other states have created prevention trusts or funding streams, notably Massachusetts and Minnesota. This will be an urgent and necessary first for California. Chronic disease accounts for 8 of every 10 deaths in California, and just 6 conditions, 42% of public health care expenditures, or $98 billion a year, with an additional indirect cost of $51 billion. It affects 14 million Californians, including many of us here in the room. And it does so with devastating unfairness, exacerbating our underlying social inequities. Most cases of heart disease, stroke, type 2 diabetes, and many cancers can be prevented by eliminating their underlying risk factors. So with this level of impact, why aren't we acting to prevent them? Just to give an example, I'm a pediatrician. My husband is a critical care doctor. Our two professions see these illnesses from the beginning to the end of life. On Saturday, my husband saw a 56-year-old younger than me felled by a massive stroke. That is exactly the type of preventable event that we believe that building healthier communities through this approach can help to prevent. Yet despite this, our investment in primary prevention has been minimal. The proposed fund is a prudent investment in the well-being of our state, and it actually won't take that long to get your money back. The Trust for America's Health has estimated that $1 invested in these types of programs will be returned within 1 to 2 years, and within 5 years, a return of $5.6 per dollar spent. So this $380 million, or $10 per head, proposal of Assemblyman Gomez's would support community-based chronic disease and injury prevention that will address the well-recognized underlying behavioral and social determinants of illness, including poor diet, physical inactivity, tobacco use, and violence. The largest block would go to local public health departments, working with community partners. The funds would reach all counties and prioritize disadvantaged communities, allowing continuous, reliable prevention opportunities. The rest would go to community-based organizations and nonprofits, and it would be administered by CDPH. Each community would use funds differently according to their needs under rigorous state oversight. We could see outcomes like healthier food and water in hospitals, schools, and neighborhoods, safer, better-equipped parks, incentives for low-income residents to purchase fresh fruits and vegetables, or work to prevent violence in a neighborhood where early death or injury is the common fate of youth. To prevent these diseases that drain our healthcare dollars requires sustained, reliable, and flexible investments in each of our communities that can lift them out of poor health, save money, and create a healthier future for our children and youth. So we call upon you to think about this new Health System 3.0, I think he called it, and prepare California to lead the nation by investing in prevention. This cannot wait, and the cost of our inaction has been far too high. Thank you.
Thank you, Dr. Silver. Anything, Mr. Starr, anything you want to add?
No, we don't have any comment on this proposal at this particular time. We can certainly say, and you heard from Dr. Smith earlier about our goals and vision and Let's Get Healthy California, and the activities that are described in this proposal, upstream prevention, are very consistent with things that we do in our department and with our long-term vision.
Thank you. Anything from Finance? LAO's office. Any public comment? 1 minute each speaker. Public comment.
Mr. Chairman, Jerry Jaffe, representing the California Chronic Care Coalition. We support a trust fund in concept. However, if the $380 million is unattainable in funding this year, or you get signs from the governor that he would not support that amount, I suggest what you do instead is come up with a schedule that, for example, this year you might fund it for 1/3. Next year, another 1/3, and then the following year, 1/3. But keep the amount in the budget as the goal. That's really important, and work to that. So support in concept, and then obviously we'd like the full funding. If not, don't knock it down. Just try to do it in incremental steps. Thank you.
Hello, my name is Juliet Sims, and I'm here representing Prevention Institute. We are an organization based in California that spent nearly 20 years studying the kinds of interventions that can work in communities to reduce chronic illness and reduce injury. And what we know is that improving community environments through initiatives such as the ones Dr. Silver emphasized with this fund are really the foundational efforts that are required to improve health and reduce health inequities. And yet, funding for them remains elusive in many cases. Nationally, we only spend 3 cents on every healthcare dollar to go towards prevention and public health. So we believe that this kind of fund could really be a boon to California's communities to reduce health inequities and continue the state to build on some of what's made us innovative in terms of addressing public health disparities. Thank you.
Thank you.
Hello, Mr. Chair. Callie Hampton on behalf of the American Heart and American Stroke Association. We are facing an incredible obesity and diabetes epidemic in this state, and without any funds going towards chronic disease prevention, we are looking at a really big disaster and are very, very supportive of this proposal. Thank you.
Thank you.
Hello again, Matthew Monson with Public Health Institute. Just to say we're in strong support of this proposal. We do have some suggested language changes and clarifications and look forward to working with staff as this proposal moves forward through the process. So thank you very much.
Thank you.
Hi, Michelle Givens with the County Health Executives Association. We represent local health departments throughout our state, and we're supportive of a wellness trust and concept. We do recognize that prevention efforts in our state are severely underfunded, and there needs to be a stable and reliable funding source for prevention. And we think that this will better the health of all Californians, as well as reduce healthcare costs in the future.
Thank you. Any other public comment? Seeing none, we're going to leave this open, but thank our presenters and our public comment. Thank you, Dr. Silver, for your testimony.
Thank you.
Thank you. We're going to move to issue 12. It's an oversight of violent death data collection. And shortly after that, we will move to, we have a number of issues related to dental issues. And we're going to start when we move into that suite with issue number 15. I see my colleague here, Assemblymember Lowe, and we look forward to hearing from him and the advocates on that proposal. So let us take issue 12. We welcome our presenters, and we look forward to beginning there.
So what we'll do on this one is respond to the agenda questions about violent death reporting systems in general. And
thank you.
Greg will do that, and then we can answer any particular questions. Oh, thank you. That you may have.
Thank you, Dr. Starr. So the first question was to please describe the national and state violent death reporting systems, their histories, and current status. So from 2005, and thank you for the write-up. It was a great job. I'm going to go over some of it, make a few clarifications. From 2005 through 2010, California was one of 17 states participating in the Centers for Disease Control and Prevention's National Violent Disease Death Reporting System. I'll say NVDRS from here on out. CDPH contracted with county health departments to collect data on violent deaths from 4 data sources: death certificates, coroner medical examiner records, law enforcement reports, and crime lab reports, or records. During its 5 years of data collection, CDPH compiled detailed information on circumstances of more than 11,000 violent deaths, including homicides and suicides in Alameda, Kern, Los Angeles, Monterey, Riverside, Sacramento, San Francisco, San Joaquin, San Mateo, Santa Clara, Shasta, Solano, Stanislaus, and Yolo counties, which encompassed approximately 57% of the state's total suicides and 2/3 of all homicides at the time. However, due to California's size and privacy concerns and lack of resources amongst law enforcement agencies, California was unable to obtain law enforcement and crime lab records required by NVDRS and could not reapply for funding for the next cycle beginning in 2011. So CDPH realized this incompatibility early during the NVDRS grant period and secured funding to develop what we call the Cal EVDRS, the Electronic Violent Death Reporting System. So we modeled it after NVDRS, meaning the data elements were the same as the specifications for NVDRS, and took advantage of California's electronic death registration system, which permits counties to file death certificates electronically. We used funds from the David and Lucille Packard Foundation to create a violent death supplement to death certificates in Cal EDRS, which captures more detailed information from coroners on violent death. Because detailed data were not available from law enforcement, summary homicide data from the California Department of Justice's supplementary homicide reports were linked to provide as much information as possible. Cal EVDRS was successful in recruiting participation from many coroner and medical examiner jurisdictions. However, recruiting law enforcement involvement has been more difficult. Currently, law enforcement jurisdictions can voluntarily share data, but there are several perceived barriers to this data sharing, including concerns over authority to share, confidentiality, inconvenience, and costs. So currently, there are no state funds or federal funds to support the program. The California Wellness Foundation has provided CDPH with funding to reimburse coroners for completing the supplementary homicide reports. But only Los Angeles County has been able to continue to participate in Cal EVDRS consistently over time. This does not mean that we don't collect information on violent death. So we do continue to collect data from the individual vital statistics data sources, which are from the Office of Statewide Health Planning and Development, hospital inpatient discharges, and emergency department outpatient visits, and can provide basic public health surveillance on violent injuries. These data include the full range of assault and self-inflicted injuries, including suicide attempts, assaults, unintentional firearm injuries, etc. I'd mentioned earlier that we were unable to apply for CDC funding back in 2011, but we did apply in 2014 because we thought some of the constraints were not going to be as challenging as they had been previously. We received a passing score in the application, but CDC didn't have enough funds to support all states that had passing scores. In the last 2 weeks or less, the CDC has issued a new funding opportunity announcement to fund more states to do NVDRS. And we hope, we've been working with them over time to try and they have been working and acknowledging that large states have more challenges in collecting this data. So this funding opportunity announcement, we hope, will address some of those concerns that we have, namely, I think there'll be less burden on collecting crime lab data, and that we will hopefully be successful and get the funds this time around for NVDRS.
Thank you. Anything from finance? Anything from the LEO's office? Any public comment?
So, Matthew Marson with Public Health Institute. I first wanted to say thank you to the committee to raising this important issue. I think it's absolutely critical. PHI works in about 20 countries around the globe, and just what it's been demonstrated through the evidence of our work is that both perceived and actual perceptions of violence in community is a really critical barrier to building healthy communities, and we just want to do all that we can to ensure that we're gathering the data in California around these issues, and particularly want to draw attention to the issue of gun violence specifically. So thank you, and we look forward to supporting on this issue as it moves forward. Thank you.
Thank you. Any other public comment? Seeing none, we're going to move on. Thank you, Mr. Oliva, for the presentation.
There was a second question?
If you could, just very briefly, we're going to move on to the next set of. Please do.
We could send it in writing, or we could. It was just that. Please explain how this data could benefit the national system, and also how it could be used to benefit and potentially reduce violent injuries and deaths in California.
Give us your brief response.
Okay. So the NVDRS is the only state-based surveillance system that pools data on violent deaths from multiple sources into a usable, anonymous database. And what this does is provide more of a who, when, where, and how as to how these violent activities take place. I'd mentioned earlier that what we're able to do is really considered passive surveillance. This NVDRS is much more of an active surveillance, where you get a lot more rich information as to why these things happen, and so that communities can plan around and develop interventions to address that who, when, where, and how.
Thank you. We're going to move to issue 15. We'll return to issues 13 and 14. Issue 15 is a stakeholder proposal, virtual dental homes. The committee welcomes Assemblymember Lowe, who will provide some context on the proposal, as well as Catherine Dressler from the Children's Partnership. Please come forward. Assemblymember Lowe, would you like to open on this issue?
Yes, if I might. Thank you very much for the accommodations as well, Mr. Chair. And many of us have talked about the virtual dental home grant program, and I know that I've spoken to you in depth about this as well, and we share a passion for providing health services to particularly underserved and underrepresented communities. And let me be very brief. California's oral health disparities are more severe than the national average, and statistically, 1/4 of children in California have never seen a dentist, and approximately 65% of elementary school children are in such need. In 2014, the virtual dental home pilot project was made permanent after its successful pilot program, which demonstrated the early disease prevention which could be provided safely and effectively in community-based sites by allied dental team members who are connected with a dentist and off-site locations. And in addition, 20 underserved communities around the state have been identified that could potentially be of service to this particular grant program. And the target of 20 low-income and underserved communities, which would result in over 20,000 children and adults being able to be served through this grant program. I also did want to mention that earlier last week, the Little Hoover Commission released a report on fixing Dental Cal, and one of the recommendations was for the legislature and the governor to find a statewide expansion of teledentistry and the virtual dental home. This appropriation would be a one-time $4 million allocation to establish such a program throughout the state of California. And so I appreciate the opportunity to speak with you here today, and of course have other individuals, Kathleen with the Children's Partnership, and Brianna Pittman with the California Dental Association, who can also help answer any questions.
Thank you, Assemblymember Lowe. We appreciate your interest and leadership on this issue. Very strategic of you to reference how it was included in the report of possible solutions. Very strategic of you, and we appreciate it. We won't be taking any action on it today, but as you've been really an advocate for this, we appreciate your leadership on this, and we'll continue the conversation.
Thank you very much.
Thank you, sir. Ms. Dressler?
Kathy Dressler with the Children's Partnership, and we're a sponsor of the bill that Assemblyman Lowe was carrying last year, AB 648. That bill and this budget item would accomplish the goals of 648. Tooth decay is the most common chronic disease and unmet health care need that California children face. And a majority of California's children are covered by Medi-Cal. Most parents are unaware that their health coverage for their children includes dental coverage, and even for those that do, the transportation issues and difficulty in arranging time off from work makes it very difficult for them to get their children to preventive dental care visits. Virtual dental homes are unique in that they provide an authentic dental home at the places where these kids are every day, K through 12 schools, Head Starts, and other daycare sites. And we would like to see the state invest in those kinds of, as you did in your own district, in those kinds of programs that will serve kids where kids are at. AB 648 unanimously passed the Assembly last year to establish and fund the equipment and training that is necessary to bring this program to scale. And when the time comes, we would appreciate seeing this subcommittee support this very modest $4 million investment. Thank you.
Very modest. Thank you.
Very.
Thank you. Finance might agree, but nonetheless, anything from finance? Might not agree. Anything from the LAO's office? Any questions from the committee? Any members of the committee? Public comment.
Good afternoon. Brianna Pittman with the California Dental Association, also a co-sponsor of AB 648. What we've seen is the virtual dental home has been a really impressive model for bringing prevention to certain populations in the community settings, while also providing links to comprehensive and coordinated care in the dental team. So when it's time, we would urge your support of this proposal. Thank you.
Thank you.
Janice Canalum with the Children's Defense Fund of California, and I just want to echo a strong support for the comments of my colleague from the Children's Partnership. And I'd also just like to take a minute to point out that this is a really creative solution to a big problem, and the need for meeting children where they are is a good way to get them. Thank you.
Thank you.
Hi, good afternoon. Eileen Espejo from Children Now. Also just wanted to voice our organizational support of the virtual dental home as a cost-effective, innovative practice that also promotes team-based approaches for the dental team to meet children's dental care needs. Thank you.
Thank you.
Tam Ma with Health Access California in support.
Thank you. We have a few items where we'll be talking about things like children's dental disease. We'll be hearing from the department. I know that you have other issues, but, one of the things that we keep hearing is that we just can't do enough because of access issues. So we think that this is certainly an important part of the conversation. Assemblymember Lowe, did you want to close with anything on the subject?
Well, I just know that you have many different competing interests, but knowing that we can use technology in an effective way to serve those most vulnerable is an effective way to address some of these issues. And so I applaud you for the efforts and along with staff to be able to just find the best solutions for our state.
Thank you, Assemblymember. Appreciate you. Thank you.
Thank you very much for the accommodation.
Thank you. Thank you, Ms. Ressler. Continuing in our conversation about dental issues, we are pleased to welcome the State Dental Director, Jay Kumar, who is here. And we will have an overview of the Office of Oral Health from Mr. Kumar, and we'll hear from Finance and ALAO's office. Welcome.
Thank you. Thank you, Mr. Chairman. My name is Jay Kumar. I'll give you a brief overview of the State Oral Health Program. We have we are working on several issues. We have made steady progress towards certain benchmarks established by the department. The disease burden document is under review. We have had several meetings to develop the state oral health plan. We are working with an advisory committee and several work groups. We have increased our capacity to perform public health functions by hiring several staff members. We have 2 grants. Both of them are from the Health Resources Services Administration. The first one deals with perinatal oral health quality improvement project, and the second one is an expansion of the California workforce models. You've asked me to describe share the vision of our oral health promotion in California, and also to describe the primary functions of the Office of Oral Health. Our vision is to achieve equity in health and wellness. This is accomplished by creating conditions to prevent diseases and promote early detection and prompt treatment. We are working with DHCS, other state agencies, partners, and stakeholders to obtain guidance to achieve this vision. We also utilize the Centers for Disease Control and Prevention and the Association of State and Territorial Dental Directors guidance documents to develop the state oral health program. The functions of the state oral health program are aligned with the 3 broad functions of public health. Those are assessment, policy development, and assurance. Our priorities are setting achievable population health goals and outcome measures, developing a surveillance system to track progress, advancing policy systems and organizational changes to achieve improvements in oral health, leveraging strategic value of partnerships and collaboration, promoting evidence-based practices, and finally providing technical assistance to local health departments and programs. You've asked me to answer 2 questions. The first one deals with stakeholder participation efforts. We have a broad-based advisory committee and 4 work groups representing many organizations. We have obtained their input in identifying problems, issues, and also developing solutions. And we are in the process of developing goals, objectives, and strategies for the state oral health plan. We have attended a number of meetings of key organizations and shared the state oral health development process. We have met with organizations like First Five Commissions and attended meetings of professional organizations, also meetings of oral health coalitions, local strategic planning groups. We have plans to attend several more meetings in the next couple of months. The second question you've asked me is about state oral health plan. The purpose of the plan is to describe how the Department of Public Health, our partners, and the communities we serve will work together to improve the health of the population. This provides a common agenda and a roadmap for action for communities, stakeholders, and partners. It is designed to set priorities, direct resources, and promote effective programs and policies. We are using a collaborative planning process with input from members of the advisory committee and several work groups. We have engaged the advisory committee to identify major problems in California with respect to oral health and to develop a framework. We conducted an assessment which included an environmental scan of existing reports and information. We assessed the progress with respect to various national and state health goals and objectives. We identified several goals and objectives for inclusion in the state oral health plan. For example, the California Wellness Plan, a roadmap developed through a collaborative process, has identified several access to dental care as priority. The Healthy People 2020, the nation's 10-year goals and objectives for health promotion and disease prevention, has benchmarks for achieving oral health. The Centers for Medicare and Medicaid, as well as the Health Resources Services Administration, have performance measures, as well as the Department of Healthcare Services here in California. So we reviewed evidence-based interventions, proven practices, and promising approaches to help identify strategies for addressing identified goals and objectives. So as I said before, we are working with several work groups and the advisory committee to finalize the objectives and strategies. And we're also in the process of selecting priorities for action in the next couple of years.
Thank you, sir. This committee looks forward to working with you. I know that this has been a position that's been vacant for quite some time, so your arrival is highly anticipated, and we are excited to have you here. I note that you're going to be participating on one of the other panels as we speak. When you do, I'm going to give you a heads up. This is something I always do. I'm going to have one question for you and for Ms. Cantwell and for Director Kent. It's always the same. How do we address the access issues, in particular for children? You don't have to answer it now, but I always like to give my partners a heads up of where I'm going. And so we are excited to work with you. This committee is committed to doing anything that we can to address those issues, and we look forward to our ongoing work together.
Thank you.
Thank you. Anything from finance? Anything from the LEO's office? Any public comment?